Good morning, good afternoon, and good evening. My name is Barry Blake. I'm a Vice President of Research at SCM World. And today I'm delighted to introduce Brent Petty and Karen Conway, two individuals with tremendous understanding and experience dealing with systemic healthcare challenges. Brent, Karen, how are you today?
We're doing quite well, or I'm doing quite well.
Yeah.
I guess I shouldn't speak for you, Brent.
Yes, very well. Thanks, Barry.
Excellent, excellent. So Brent Petty is the incoming chair of the Association for Healthcare Resource and Materials Management, or AHRMM, those who are familiar with the acronym. And he's also a vice president of supply chain at Wellmont Health Systems. Karen Conway currently sits on the board of AHRMM, and she's also a board member of the Arizona State University Health Sector Supply Chain Research Consortium. Karen is a co-author of Leading from the Edge. She's a published author, a book on global leadership that was published last year. Both Karen and Brent are going to talk to us about the cost, quality, and outcomes movement in healthcare today. So with that, Karen, I think I'm going to hand it over to you to get us started.
Thank you very much, Barry. It's a pleasure to join you and also Brent this morning, two of my favorite folks and two individuals I have learned a lot from over the years. We're going to talk about a topic that is both Brent and I are very, very passionate about, and that is the role that the supply chain can play in helping us get to better cost, quality, and outcomes in healthcare. Healthcare is one of those industries that touches everybody. I mean, at some point or another, we're all patients. And so whether you work in healthcare or you don't, we all care about, can we solve our current healthcare crisis? Can we deliver better quality care at a more affordable cost? And we believe that the supply chain is an often underlooked but very strategic player in our overall efforts. So we're all familiar with the Healthcare Reform Act that was passed that is designed to really change our healthcare system from one that rewards volume of care to one that rewards value of care. But this is not really just a U.S. issue. Wherever I go in the world and people I talk to, whether they're working in hospitals, whether they're a global supplier, whether they're a regulator, everywhere, Australia, Europe, Canada, China, all looking at how we can, again, understand what drives value in healthcare, what delivers better quality care at a lower cost. This is a slide that shows the financial reality. So if you're not sitting in a hospital, if you're not the hospital CFO, you may not be quite aware of the dramatic cuts that are coming to hospitals across the U.S. So while I said it's a global issue, I'm going to talk specifically to some U.S. issues here. This is an analysis that was done by the Healthcare Financial Management Association and talks about, there's an analysis of all of the various impacts. So it's not just healthcare reform. You do see things, you see the Medicare productivity here, Medicare dish payments, those are direct impacts of the healthcare reform. And basically, they're looking at how do you offset the additional revenues. In other words, they're going to cut payments because there is this assumption that hospitals and healthcare systems will receive more revenues as a result of more people being insured under healthcare reform. Now, the challenge is, when you look at it, Medicare and Medicaid patients, hospitals lose money on Medicare and Medicaid patients across the board. And then if you look at how people chose insurance under healthcare reform, many of them went to that plan that offered them the lowest monthly premium, which often equates to very high deductibles. And so many people are still putting off care. And as a result, you end up seeing people still showing up in the emergency room, the most expensive place for care to be delivered, and in many cases can't pay their bills. So we haven't necessarily changed that much. But at the same time, we're also seeing encouraging signs such as reduced hospital admissions, reduced infection rates in hospitals. So at the same time, we are getting better at delivering care, and those readmissions and those infection rates are oftentimes significant contributors to cost in healthcare. On top of all of that, you see the impacts of the overall sequester on hospitals. and you see the impacts of the American Taxpayer Relief Act, which also called for reductions in payments to hospitals due to some alleged overpayments for the severity of patients. So lots of, if it's the government, you can expect that it's going to be a bit complicated. But the bottom line, as a good friend of mine who's the CFO at the University of Alabama Hospital said, these are the good old days in 2013 and 2014 and 2015 if you look at the significance and the number of cuts that are coming as we move out over the next 8 to 10 years. So what do hospital CFOs think that this is going to do? Well, most of them say we are going to see commercial payers. The government is already doing it. We're going to see the commercial payers putting more revenue at risk based on the ability of hospitals to prove that they can lower costs and they can improve quality. And most of them are seeing this rolling out in what's called pay for performance, which measures and then pays hospitals based on efficiency and also quality outcomes, and quality includes the patient experience. There are a number of other payment methodologies coming down the road, like bundled payments. That's where instead of, if you went in for a total knee replacement, instead of paying the surgeons separately, the anesthesiologist, the hospital, the aftercare, the physical therapist, there's actually bundled payments going to all of those individuals. But the bottom line is that there's more payments, more revenue at risk. So if we look at what the government is looking at, they see value as a function of quality, efficiency, safety, and cost. And I'll give you an example here. This is for value-based purchasing. And the bottom line is that high performers get paid more. But remember that all hospitals are seeing a cut across the board. And basically, those cuts are going to go into a pool of money. And some of that money then would go to pay those. In other words, you can earn back some of your cuts. It's not like you're going to get increased revenues over years gone by. And at the same time, you could even see further reductions. If you're not able to improve efficiency, improve the quality of outcomes, and improve patient experience. So it's also in the eye of that consumer, if you will, the patient. So you're measured on your achievement compared to others across the country, and you're also measured on your own improvement. Can you get better over time? You're measured on, it's a function of core measures, which I'll talk about in a bit. Those are quality-based, clinically based. And then what we call HCAP scores in healthcare, which is basically how the patient is evaluating their experience, their satisfaction, and that turns into that overall performance score. So over the years in the past, core measures have been typically process-based, things as simple as did a patient exhibiting heart attack symptoms when they walked into the emergency room? Were they given an aspirin? Were they given primary PCI, percutaneous coronary intervention? You may know it as balloon angioplasty. It's basically within 90 minutes if a patient presents certain symptoms, are you opening up that artery? Are you giving them correct discharge instructions? If somebody is a smoker, are you talking to them about smoking cessation programs? Or are you giving them very clear discharge instructions? Follow this protocol, take your medication. But those core measures are now moving to what we see as far more supply dependent. An example, a catheter-associated urinary tract infection doesn't happen if you don't have a catheter in place. Falls and trauma oftentimes occur as a result of, was the floor slippery? Was a patient given socks that provide some traction when that patient gets out of bed, perhaps, and is walking over to the bathroom in their room? Or for a bit of levity, sometimes it does require communication among the various parties. These are clinicians, but we, as we'll talk about with the cost quality outcomes movement, talk about the importance of the supply chain leaders, the clinical leaders, the other operational leaders, facilities management, for example, engineering, the financial folks. We all need to be working together to understand what's the best that we can do to provide better patient care at a lower cost. So I've mentioned value. It really is all about value. And just to simplify things, as I said, there's a lot of complicated government equations that will determine reimbursement and lots of different types of legislation, not just the healthcare reform that's impacting those payments. But to put it very simply, value is a function of quality and the cost to deliver that quality of care. This is the dilemma that we face in healthcare. Professors Kaplan and Porter wrote in their book, The Big Idea, and a great article, I think it was in 2010, 2011, in Harvard Business Review. The challenges in healthcare, because the way that healthcare has reimbursed, or CMS, Centers for Medicaid and Medicare Services, or commercial payers have paid hospitals, healthcare systems, doctors in the past, has been on the volume and for certain procedures. And as a result, there really hasn't been a great need for cost accounting to truly understand how much it costs to deliver patient care. And that's looking at the big picture. How much is it, to pay the nurses, to pay the doctors, to keep the operating room running, to provide the supplies that are necessary, to keep the lights on. All of those different costs, the legal fees, the other kinds of issues that you face there. And then how do those costs, if you actually understood them, compare to the outcomes achieved? We hear a lot in the press about hospitals. Why can't you tell me how much it's going to cost for me to have this particular procedure? When in reality, many, many hospitals simply do not know how much it's going to cost them, let alone how much they're going to charge under a rapidly changing reimbursement system. So we believe that the supply chain, because the supply chain represents the second highest and fastest growing operating expense in hospitals, it can play a very important role in improving efficiency and also giving visibility that data that you need to start doing some of that cost accounting and that relationship to outcomes. What products were used on which patients, by which clinicians, in what facility, and then tying that to the cost and to the outcomes. And when I say outcomes, we talk about quality as well as that reimbursement, that financial outcome. Quickly, in terms of the importance of supply chain to healthcare, I mentioned that supply chain costs are the fastest growing. There was a study done by Strategic Marketplace Initiative that worked with the marquee name IDNs, and they looked at the rate of increase of supply chain costs compared to labor costs and saw that at one organization, supply chain is going to supersede labor in less than 10 years. Gartner has estimated that hospital operating expenses represented by the supply chain are about 40 to 45%, with the potential supply chain cost reduction with better supply chain management of 5 to 15%. Unfortunately, that same study said that most hospitals don't have sophisticated enough supply chains in order to achieve those kinds of benefits. The other issue is that supply chain, if you look across, the SG&A costs incurred by manufacturers significantly higher for healthcare organizations compared to other industries. In this world where getting top-line revenue growth is extremely hard, the fact that it's much, much easier to have an impact on the bottom line through OpEx reduction plays a very, very important role. Certainly, if you can automate processes, for example, orders, invoices, et cetera, you can see a significant reduction in your costs, as well as better operating cost revenues or ratios have been identified by Oracle Healthcare Insights in terms of those organizations that are investing in back office automation to do that that electronic purchase order, that electronic invoice, and a wide variety of other types of transactions that give you visibility into your supply chain. They're seeing 2 to 4% better operating cost ratios. So one of the areas, probably the most expensive place where care is provided in the hospital is in the operating room, in the cath lab, but it's also one of the most expensive. It also tends to be one of the most profitable. So I was speaking the other day with a VP of supply chain for a major healthcare system to a group of orthopedic manufacturers, and he was talking about the fact that, oftentimes hospitals and healthcare systems will really beat up manufacturers based on the fact that you're enjoying really good margins while we're barely keeping our doors open. His comment was, he said, in the OR and the cath lab, that's a bit disingenuous because that is the one area where hospitals tend to make more money. That money is needed to offset all of those places where they're actually losing money. Remember, I said that most hospitals lose money on Medicare and Medicaid patients, and likely on many of the newly insured. But the key is that so you can sit there and fight over whose margin these reductions have to come out of, or we can look at the significant amount of waste. And if you look again at those SG&A costs that I referenced, that's where that waste is really evident. In the OR, we've done some studies at GHX that look at the fact that this is probably a $5 billion plus annual problem, and it's a problem that's equally shared by providers and manufacturers, and oftentimes in very common areas. The amount of product that is lost, that expires, that is wasted, even dropped on the floor, that's wasted, before it can be used. A manufacturer told me anecdotally that he had 2 years of inventory out in the field that was going to expire in 18 months. That's a significant cost to all of us. We have very low inventory turns. We have lack of visibility. We do things very manually in the OR and the cath lab, and that contributes to this area of waste, and I would say this opportunity for collective savings. I'm going to turn this over to my colleague Brent because he lives and breathes this every day.
Oh, absolutely, Karen. Thank you so very much. This is a great slide that shows a shared problem within healthcare, but something that other industry partners throughout our continuum has really already fixed. So as you look at problems that create potentials for lower quality or create increased cost, I have here a slide from the advisory board that's a cross-industry comparison of different industries and how they perform with quality and efficiencies. And we throw in a definition, efficiency, very simply the ability to do something well without wasted energy or effort. So as we look at our other industries that we compare to, with airlines and banking and computers and telecommunications and auto manufacturing, the hospitality industry, we look at quality, meaning how many errors do you have? And we look at efficiency, and we look at healthcare. It is very low in efficiencies and very high in quality. And we hear about the big ones, wrong site surgeries and pharmacy errors, infections and falls. We all hear about those, but I think we need to take it a little bit deeper, as the previous slide says, in that a lot of our industry is riddled with the inefficiencies because of variation. We won't drill into that just a little bit, but really we need to put some thoughts about unlearning some of the things that we've already learned. So we need to challenge to think differently, and when we think differently, we begin to act differently. So supply chain here, we can no longer be focused on what we used to focus on, price. Can we get a discount? Can we get some different delivery terms or some different payment terms? But rather now we've got to look at the combination of really the cost, quality, and outcomes, and how complicated it is to take a patient through the healing environment. But likewise, if you think about the airline industry, how complicated is it to get a passenger from one place to the other safely, efficiently, and cost effectively? So other industries have addressed this and done a lot of work to solve it. So as we look at the CQO movement and we begin to think differently, we want to go ahead and make sure that because there's just a complete lack of understanding of what it all takes to deliver our care, we need to put some definitions around what is cost. The total cost to deliver patient care. It can be that simple. Outcomes. We define it at AHRMM for CQO as financial reimbursement driven by outstanding care at the appropriate cost. And then quality. Truly the patient-centered care aimed around achieving the best clinical outcomes. So as we begin to ask people to unlearn and ask to think differently, we want to set some standard definitions of what we were talking about under CQO. So really we want to look at where supply chain owns the intersection of cost, quality, and outcomes. What I'm saying here, as with any industry, supply chain doesn't own all the cost. Karen described some of the things that really fall outside of the supply chain's control. And we certainly don't influence all the quality, but all the cost and quality comes together to create that outcome. So we believe that supply chain today in healthcare, as other industries have demonstrated, is the perfect position to manage that intersection of cost, quality, and outcomes. Not to own it. We're not stepping up and saying we're taking all the cost or we're going to control all the quality, but we're really going to step in and manage that intersection between cost, quality, and outcomes. So here's just a brief study around drug-eluting stents. We have some physician data here, some usage data. So stents are a common implant used when someone has a heart attack. And right here we show from our data that the average number of stents used during a PCI, right after or during a heart attack episode, Medicare has shown with the most recent data that about 1.5 stents per patient is the average. So as we look across the challenges, that clinical variation and practice variation is probably the biggest threat to cost, quality, and outcomes. And what I mean is, we look at clinical variation. What do the physicians doing the same procedure, how do they do it differently? Practice variation, I'm gonna leap over to like the back room operations. How does one hospital function efficiently with electronic tools versus doing the old manual tools? So we have clinical variation and practice variation. And right here we're looking at a clinical variation that physicians average higher than 1.5 stents per patient really are creating a large cost increase in our industry. But data is beginning to show that the outcomes, the quality that comes from that is very, very likely not to be much different. So in a perfect world, if I was king of the day, I could go to all these physicians and say, hey, if you can get to national average of 1.5 stents per patient, this is how much money just these 6 physicians would save. Well, we have 3 physicians that are above average, and that cost is almost $1 million, just in 3 physicians being above average in the number of stents that they use to treat a heart attack. Now, we do understand that there are variabilities, within our patients, and we do have to make some assumptions here. The assumptions is that we've adjusted the risk. It's risk adjusted, meaning that we took into consideration and made the appropriate adjustments to our data that some patients are sicker than other patients. We get that. Whether you're having a routine physical and you discover that you have some heart concerns and you schedule a procedure, is a lot less expensive to treat than if you're in the back of the helicopter landing on a trauma pad being rushed into a cath lab. So our assumptions are that we've risk adjusted it. We're using the same payment explanation. It's what we call the MSDRG, using the same cost, using the same averages, saying, our room cost is, 1 hour is equal to $1,500. So when we're doing this, our assumptions, we try to level across the board. And we want to look at really stage 1 here, and who all does it involve? So as we look at it, and I'm not going to walk through all these bullet points, but our direct stakeholders are our interventional cardiologists, and that's where we're just a little bit different than a lot of other industries, where the stakeholders are the clinicians who are providing the service as well as the patient receiving the service. So we sort of have a two-stage stakeholder intervention here. So as we look at next steps, really, if you look at treating heart attacks and using a stent as one of the implants to treat this heart attack, what is the current state? What is the cost? So, it's adverse event. If done correctly, we want to have this patient leave our facility, assume their outpatient care, and really go forward without having any complications, being readmitted. And that really provides us the opportunity to reduce our costs going forward. The reduction in case based on a per hour rate, and we also get penalized for the readmission. In outcomes, we want to make sure that we're using the same DRG reimbursement. Fewer hospitals are going to have these resources to do these procedures. Declining number of stents, increased caseloads, all those are the current states in the outcomes using this current case study. So quality, this is where it really gets to be a challenging state within our hospitals, is the quality is often anecdotal based instead of clinically evidence based. One of the biggest challenges under CQO outside of the clinical variation is really the practice guidelines that lead us to evidence based. So often when we look at it in this particular example, drug-eluting stents, our physicians go off of their own experiences and say, when I have a heart attack patient with this big of a lesion within their artery, I usually use 2 or 3 stents to do that, and that's been my best clinical outcome. Well, that is a practice-based anecdotal outcome, as opposed to going to reviewing practice guidelines from the industry experts that really step up and give us what should the average number of stents be put into a PCI patient. So we go back and we look and say, okay, what are our principles that we need to apply? What do we need to do to address the biggest threat within cost, quality, and outcomes is that clinical variation and that practice variation. First off, you've got to recognize that as you use these products and as the data becomes available behind that usage, you have to rely upon your supply chain as a contributing factor to patient care. At the end of the day, your utilization, your standardization of your practices around your supplies will lead you to better patient outcomes, lead you to better patient cares. Supply chain is a critical part and has to be elevated up, as other industries have done, as part of the real strategic plan in managing that hospital. And unfortunately, today we have some supply chain leaderships that have not been prepared to develop a strategic plan, to be able to be that resource, to become that intersection of cost, quality, and outcomes, to be that leadership team, member of that leadership team that's changing how we think, and really will change how we act differently. So AHRMM is committed to getting the message out, providing the toolkits, providing the education opportunities, the peer interactions, and everything is successful needed to elevate the supply chain as part of the strategic management part of the hospital. And you've got to recognize that all stakeholders need to be educated. CQO has been a fantastic movement and adopted very quickly by our supplier partners. They've looked at us and said, hey, this is what we've been asking you all to do, is to base your cost on the total cost of delivering care, to base your quality on evidence-based practices, not anecdotal or preferences by a physician. But all stakeholders need to be educated, including all the way down to the caregiver up to the C-suite in our hospitals. And with that, how do you bring about that education? you've got to begin with metrics. You know, under this new healthcare movement, under CQO, we're required to come up with some metrics that really, first and foremost, are simple, they're measurable, and they're repeatable. So within healthcare, you've got to establish your baseline. So it requires those metrics to transition us from that volume-based thought process and practice over to delivering value-based. And we have to find a way to measure that. So with that, AHRMM is committed to having a real toolkit that we can start with. This is one that has been developed and used within our hospital system. And we basically look here in orthopedics, and here we've chosen a total knee. This is the procedure that most hospitals perform. And as we see here, the clinical variation in delivering care shows up in our cost. So in column 1 here, you see our least expensive surgeon is in the $8,000 area. Our most expensive surgeon is in the almost $12,000. That's a 20% variation within our surgeons. And I do qualify that surgeon 1 is a retiring surgeon who has been fantastic in delivering care over the past 20 years. And he's delivering it at an inexpensive cost. So as you can see, if you just go across there and look at, just not to exceed the group's average, if all of our surgeons just function to average cost in delivering these care, this hospital could take $229,000 out of their operating budget. But if you look at the extreme, if you go over to best in class, and these surgeons all have the same opportunities, they use the same OR, they use the same payer mix, they have the same clientele. So you look at them and say, well, I'm rural-based and I have a less educated customer base, and they don't take as good a care as maybe someone in a well-populated area. That's not true here. All the variables have been removed because all these surgeons practice together. So if we all went best in class, if we all performed at what surgeon number 1 performed to, we would take $1.4 million out of our cost just based on variation in how we do the procedure. So other industries don't do that. When you check into one of the well-known hotels, you can count on the exact same processes to check in, the exact same amenities. And I know that's sort of a stretch, but I challenge you to look at the airline industries and tell me which airline you're on and which plane did you get on when they start telling you about the mask falling from the ceiling in the event of a pressure change, or if the lights go out, where are the floor lightings, where are your emergency exits, how to fasten a seat belt. Which airline does that? Which plane do they do it on? It's all the same. It's all been standardized for safety, and that has delivered safety within other industries, and that's what we're advocating here, is our variation in practice leads to increased cost. In this example, just one procedure within one hospital is a $1.4 million variance in cost. So we have to drill this down a little bit as we look at our metrics. So we come down and look at it based off of the surgeons themselves, and we just pick 2 surgeons to compare here, removing the names to protect the guilty here. As you look on top, you can pick one of these procedures. You can actually see that in our partial hip replacement, our second one, our physician on top is actually, more expensive in doing his implant. So his supply cost overall becomes higher. And that's the cost on the left side of this scorecard. On the right side, we give the clinical metrics. We use 4 different ones as determined by Medicare. And we look over, and he has a bit of a challenge in his readmissions. So if you look at the surgeon on the bottom, the second scorecard, he's less expensive, but he has a clinically adjusted length of stay is higher for his partial hip. So you look at it and say, you know, as we look at these volume-based procedures going over to value-based procedures, and we're trying to get the people home quicker, we're trying to get them out to do their rehab faster, we're trying to get them out of the hospital environment, because the hospital environment is the most expensive place to provide care. The surgeon on the bottom has a less expensive implant cost, but he's keeping them a couple extra days. But if you look in the long run, in his readmission, he doesn't have a readmission concern. Where the surgeon on the top has an increased cost, a less adjusted clinical length of stay, but boy, they're all coming back for some reason. So this is the metrics-based philosophy that the AHRMM toolkit is providing. And I can tell you, is this perfect? It is not. This is a real example of what we used in our health system to define that intersection of cost, quality, and outcomes. Supply chain led this project, but as you look at this scorecard and you begin your metrics-based process, my advice to you is to get started and refine as you go. Right here, this example, this surgeon, these two were very much competing against one another, in the fact that they were defending what they were doing was the best practice. When you apply the quality indicators on the right side of the page to it, it really brings it very clear that each of them have some opportunities to perform better while lowering the cost. So again, you just need to get started with your metrics and then refine them as you go.
And with that, I'm going to jump in. Oh, sorry, Brent, go ahead.
No, go ahead.
Okay. I was just going to give you, just to close out, before we do some questions, a couple of other examples. University of Virginia, a good friend of Brent and mine, Barbara Strain, who is an RN. She is also the past president of a group called the Association of Healthcare Value Analysis Professionals. Value analysis is a program that many hospitals have, although to Brent's point, there's a lot of variation in how value analysis teams work. I would say that the program that Barbara runs is one of the best, and we are working a lot on what we call leading practices around some of those core measures. So think back to the core measures that I mentioned that are more supply dependent. In this particular case, this is work done by the University of Virginia on their catheter-associated urinary tract infection. And they, excuse me, we're just jumping around for a second here. You can see here that they worked very much cross-functionally, bringing in a lot of the different stakeholders that Brent mentioned in his earlier example. And they looked at the number of infections they had, and they have been able to, by bringing in clinical folks, supply chain folks, financial folks, and looking at what's the best way to treat this. And again, it's always focused on the clinical outcome, but if we can see that there are cost variants, but the outcomes are not that different, let's look at that most efficient, that most cost effective. And by able to determine the best supplies combined with the best treatment, matched to the patient, they were able to reduce or prevent about 58 infections, and that resulted in $58,000 in savings across the organization. One point to make sure everybody understands is we talk a lot about infections. We talk a lot about readmission rates. Brent was bringing that up. Those are what are called so-called never events, hospital-acquired conditions, and they are things that hospitals are no longer paid a dime for. So if a patient comes back on an unplanned readmission within 30 days, the hospital is not paid. If they acquire an infection in the hospital is not paid for the cost of treating that. So here where you see a significant reduction, actually 65 infections presented, $58,000 in savings. Another one of the core measures is hospital-acquired are pressure ulcers. And in this case, the value analysis team at University of Virginia combined forces. They reduced 577 infections, and that resulted in $5 million saved in this particular case. So these are examples of cost, quality, and outcomes in action. I would say, to Brent's point, there's a lot of disparity, a lot of difference across healthcare. There's a statement we say, you've seen one hospital, you've seen one hospital. We would like to change that and move us all towards more leading practices. And so it's about bringing everybody up, and it's about looking at people across the entire supply chain, because we are all in this together. We will all either benefit from the improvements that are intended from healthcare reform, or we're all going down together, and we're all eventually patients. So we need to make sure that we're all in the same boat. So regardless of where the hole is, we need to be working together. And with that, I'm going to turn it back over to Barry to ask any questions.
Excellent. Thank you so much, Karen and Brent. That was tremendous. It was a great overview, great examples of the CQO movement in healthcare, which I'm sure there are some folks from within healthcare itself that are not very familiar with it, and I'm sure there's folks in adjacent industries that are breaking into healthcare and see that as an opportunity that may not be very familiar with this movement. I guess to that point, if you think about the opportunity of, it can be someone, again, it can be a health system, it can be someone who's looking at developing products or opportunities for healthcare. Where is a good place, do you think, for where does someone have to begin? Where does a team have to begin in order to start, I guess, building the foundation for them to have a successful I guess, experience initiative with CQO? Where would you begin? What needs to be in place in order for this to take root?
Brent, I'll let you start kind of in the hospital, because there's all those different stakeholders within the hospital, and then maybe I can add some comments as we look across the entire supply chain.
Oh, absolutely. Within a hospital or within a health system itself, it's the place to start is understanding what created the need for this movement. Again, I emphasize that we're creating. We make a lot of errors, and those errors come from variation in practice. They're not always seen, in an outcome. But these errors need to be identified through these clinical and practice variations. But also, you need to understand that we're very inefficient. And it's not a criticism. It's an outward look saying you're inefficient because you do the same thing two different ways. They both may be very good, but they're not the best practice. So I think you have to start in a hospital understanding what's creating your errors, what's making you inefficient, and then you can follow that to understand that your quality and your outcomes are suffering, that you're not as good as they could be because of it, and also that is driving up your cost.
That's great. Let me follow up with that, because I think it leads to the idea of what learnings I think a team would need to have to, I guess, first develop that understanding of mapping out inefficiencies, mapping out practice variation. What do you see as, if you think about, you're developing a team who you feel is going to, at some point, they're going to lead this effort. They're going to be in charge of it. What skill sets do you think they need? What types of, I don't know. I mean, we can even look at it as supply chain engineering experience. What would you expect them to have? What would you hope to develop in them in order to, again, succeed within the CQO movement?
Well, first and foremost, your supply chain executive has got to be strategic-minded, looking at that big picture and understanding that this is a cross-functional team of talent. You've got to have someone that, these talents already exist. The supply chain executive today needs to be able to take that project management mindset along with that strategic thinking process and combine it with the cross-functional talent that he already has on his team. Every hospital already has the expert on the quality outcomes. We already, even though it's very weak, we have our cost accounting system that needs to be improved, but they've got to be there. And then maybe the CMO or one of the other executives come and tie all that together with our outcomes. So if I had to describe it in a very simple manner, the supply chain executive of the today and of the future has to be like that maestro leading that orchestra. He's got to have that strong brass section and percussion section and the woodwinds, and he's got to be the one with the talent to tie all those together that makes that sound, worth buying a ticket for. So with the same thing, they've got to lead that, cross-functional talent within their facilities in order to take that cost out and identify where that quality can be improved. So they're like the maestro at the front of the orchestra.
Yep. I think it's great. I think it's a great analogy. And I'm wondering, you think of the reputation of supply chain within healthcare. You think about the reputation of physicians, or maybe it's the personality, the psychology of different physicians. And I guess if supply chain is leading the management of this intersection, right, how does someone who I guess is just getting started develop the credibility with physicians to basically drive these change? Because as you mentioned throughout the presentation, there's more than there's the stakeholder community is pretty vast. It's not just the patient, even though I think we'd like to think of that as the most important stakeholder. However, the physicians themselves. So how does someone, I guess, develop the credibility from a supply chain standpoint, particularly when you think of the perspective of the perception of supply chain within healthcare? How do they develop that credibility?
I might add something here or respond to that question. I think if you think about the physician is a scientist, and scientists rely on good, accurate, timely data from which they can do an analysis. So Brent mentioned the example with the difference in practice, the difference in cost, the difference in length of stay, the difference in readmissions among the surgeons, and how presenting them with that data starts a dialogue between the two physicians, or perhaps even more, somewhat orchestrated or at least started by the supply chain executive by giving them that good, credible data. I would say the other is to understand the stakeholders. So in this case, the physician. You mentioned earlier in one of your questions, Barry, the like engineering or industrial engineering. That's been a concept. The teachings of Dr. Deming and total quality, something that a lot of physicians actually understand. I had an opportunity to meet with Dr. David Blumenthal the other day. He used to be the head of the Office of the National Coordinator, which is the group that oversees health IT, electronic health records, meaningful use of health records, and is now running the Commonwealth Fund, highly trained internist from Harvard Medical School. And it was interesting, he came to speak to a supply chain, the Arizona State University group you mentioned before, and he walked in and he said, why supply chain? What's the importance of supply chain? And we started talking about industrial engineering practices, and he had done work 20 years ago applying industrial engineering thinking to clinical practice. And there was absolutely an understanding among the physician community that when you have variation in practice, it does reduce quality and it does increase costs. And when you talk about the fact that this can have a significant impact as well in the supply chain or in overall practice, it's not just in one area. So when you can understand the language and what makes sense, and then you make the leaps and start touching some of those other areas that impact cost, quality, and outcomes.
No, that's great. That's great, and it brings up a question, I guess. If you think how we are learning from other industries, We're applying concepts from industrial engineering. Are there concepts? Are there your understanding of supply chain as And I'm asking you to think, I guess, from the perspective of other industries. Is there anything that you feel that healthcare would benefit from a practice perspective that really has been, deep-seated or deep-rooted within other industries, whether it's automotive, whether it's consumer products, you name it? Are there certain things that you feel this industry should be really kind of trying to apply, trying to adopt, trying to fit within the context of healthcare?
I think there are three right off the bat.
Okay, go ahead.
Right off the bat, I would say standards, the adoption of standards. You think of the use of common identifiers. You think of barcodes, for example. You look at the grocery industry. The industry came together around those, the use of barcodes for a common problem. They want to move people through the grocery line, the checkout line faster. There are so many areas where standard identification of products. So it's standardization in practice, standardization and identification. And we do have the unique device identification rule coming that will help. We need to understand there are differences between retail, between grocery, and the healthcare industry. So there are things that have to be tweaked and have to be treated differently in terms of, for example, how that barcode might be scanned or that unique device identifier in the operating room at the point of use. I think demand forecasting is another key area. We just don't do it in healthcare. As I mentioned, if you don't truly understand your costs and if you're doing things manually, you're not capturing that kind of data that a hospital could be sharing with their suppliers to understand where the demand is, so we can reduce some of those inventory losses and expirations, as an example, of significant cost. Those are just a couple of the areas. I'll turn it over to Brent.
Yeah, no, that's fantastic. Absolutely, the word standards has to be first and foremost. The UDI, that's something that we should have been practicing years ago. But if you look at other industries, I described one with the airline industries, when they do their safety program, you relate that to an operating room when we do a timeout for safety reasons to make sure that the procedure and the patient is all who they say they're going to be, but we don't do it the same way every time. If you have a surgeon in one room taking out a gallbladder and a surgeon in another room taking out a gallbladder, they don't necessarily do their timeout, their safety check the same way. And see, that's that practice variation that I'm talking about. But also, if you look at the car manufacturers, when they do crash tests, when the government sets the standard for a crash test, that standard is for all the vehicles. If you have a passenger car, here's the standard that you have to meet or you don't get to sell it in this country. And whether it's a light truck, a heavy truck, all the standards are, adjusted to that category, but we don't have that same standard within healthcare. So Karen's absolutely right. We've got to get the standards, whether it's in practice or within UDI.
Got it. No, that's great. And I think one of the last questions I'd like to ask you both, I guess, is if you think about, we've been talking a lot about this from the perspective of the health systems. If we extend this back towards the suppliers, towards some of the product manufacturers, et cetera, how is this, and I think you referenced it briefly, how this is resonating with them. However, you can still see some practices where you may have sales reps really kind of driving, and they still do obviously drive the relationship with a physician, which certainly drives behavior. How are the manufacturers, suppliers kind of responding in your experience to this cost, quality, outcomes movement? Do they see it as beneficial? Do they see it as a threat to revenue? How are they looking at this, and how are they enabling it if they do respond positively to it?
They're all absolutely responding very openly and saying, hey, this is really how we want to base, our opportunity within your health system or within the healthcare industry. Now, we still do have some antiquated practices of where preference and preferences based upon a relationship. That still is very alive and well within our industry. But the manufacturers are looking at ways to say, you know, how can I increase or how can I maintain my margin? And that's no different than the way the hospitals are asking the same question. How can I increase or maintain my margins? When we look at cost, quality, and outcomes, and we set up a metrics through a toolkit and start developing standards, the suppliers within our industry are in the best position to help us with that today. They already understand what their cost of delivery is. So as soon as we get our cost of delivery up to speed to match theirs, then we become even more in line, and they can also start taking out those very expensive costs that really don't deliver any benefit, and Karen covered that in that one slide where there's consignment products out in the field that are expiring, and that's nothing but driving up cost. Having those products out there and unaccounted for is becoming inefficient. So they see CQO is becoming much more in line with the way they do business today than what we are doing in the past.
Got it. And I said that was going to be my last. One quick question on the metrics, because I think it is a critical point. Do you have to have kind of metrics alignment with the suppliers? I know you may be measuring different things, but in order for this to, I guess, truly come together, are there, I guess, similarities in metric strategies? Are there ways to bring it together where you're both looking at essentially the same scorecard with your? I guess you do this with key suppliers. That's, I guess, what I'm wondering.
You do, and even though our CQO movement is very young, you do see that we have to have those metrics and those standards greatly aligned between hospitals and their supplier partners. But we're sort of readily available to adopt each other's much more than when I have found our physician partners ready to adopt them. So I don't think it's going to be as big a challenge as we think it is, because right now we're dealing with what CMS has doled out under the HCAPs, for example, of what that metrics will be and what we measure to. So right now our supplier partners have to understand that our metrics might be a little wacky, but this is what the government has asked us to measure to. And I think with that, they're going to help us develop the metrics and standards that we really should perform together as an industry, not just in silos. Well, this is what the hospital looks at, and this is what the supplier looks at. I think we will come together very quickly on that.
Well, that's great.
And I would add,
go ahead, sorry.
I would add just very quickly, Barry, is that I think more than ever, we're really seeing suppliers wanting to understand what their customers, what hospitals and physicians will be measured on. So if you take something like patient experience, which is 30% of that value-based purchasing score. I was talking to a manufacturer the other day, somebody that sells televisions and light bulbs and different things for facilities management. You wouldn't think that, they would be that interested in the new measurements. And they stood up at this meeting and said, we're in the patient satisfaction business. We're not in the light bulb business. We're about creating that environment of care and helping our hospital customers succeed.
I love it. I love it. Developing the patient centricity. Karen and Brent, it's been a great presentation. I really appreciate you taking the time this morning, this afternoon. And with that, we'll end the webcast for today. Thanks again.
Thank you.
Thanks, guys.